Raj Geria, MD, is a board-certified emergency medicine physician with over a decade of experience in urgent care and emergency department settings. He's held academic and leadership roles, including serving as an ultrasound fellowship director and as a board member of NARUCA, where he contributes to advancing urgent care medicine and physician education. Welcome to DX the podcast, Raj.
Thank you so much. It's a pleasure to be here. I'm very excited to talk urgent care with you today. And I've been looking forward to it.
Looking forward to all your insights. Yeah. And honestly, what I find most interesting about you is how you operate on both sides all the time, meaning urgent care, emergency medicine. You practice in both arenas, but you quickly shift, right, from ER to urgent care, and you kind of see how these referrals maybe come through from the urgent care to the ER. How do you reconcile that kind of tension day in and day out, right? It probably shapes the way you view the urgent care industry as a whole.
Yeah, it's a great question. I think it really gives me clarity on the entire healthcare spectrum, working in both environments. And, I was in the emergency department full-time for 10 plus years. Mm-hmm. Then I went full-time urgent care, but I never really gave up the ER. I still work a couple shifts a month. And so what I've learned is that it's, there's definitely patients that need to be in the ER for sure, strokes, heart attacks, these kind of things. But surprisingly, there's a lot of patients that I see in the ER, and many of them sent from urgent care that really they don't belong there.
Right.
And that's frustrating because I wear both hats, right? And I'm like, well, if I was in the urgent care, I really wouldn't have sent this patient here. I would have done something different. And so that's kind of what I've learned, wearing both hats. And I feel like urgent care really can, absorb more of the middle ground instead of just being like, it's either ER or urgent care. I think the urgent care really needs to absorb more of the middle.
Yeah, more of like a continuum approach as opposed to just all in this direction, all in that direction. Because then that theoretically does leave kind of a middle ground of we're missing something here.
Right. I mean, urgent care is no longer that convenience thing. Like, okay, it's just convenient. It's a critical role. It's a capacity solution for the healthcare system.
Absolutely.
Right.
I mean, think of if suddenly all the urgent cares close their doors.
It's interesting you mentioned that.
It would be really scary, first of all.
So we did an editorial piece on that very question.
Yeah.
Because there was a similar piece. What if the ER is closed?
Yeah.
It was actually published in one of the journals. So a colleague of mine and I thought, hey, why don't we do an editorial about what if the urgent care is closed for a weekend? And it would be a mess. Yes.
Wow.
The ERs would be overloaded. The hospitals wouldn't be able to know what to do. So.
Yeah. So just to get even more kind of granular, what are some of the most common cases maybe you've seen in the ER that you just pause and think, oh my goodness, this really should have been managed in urgent care? And if you could kind of give those examples, and then just thinking about like, what can we do in urgent care today to kind of change the tide when it comes to even some of those examples?
Sure. Yeah. I mean, there's many. I don't know if you have enough time for it, honestly, but common ones that are really frustrating. I think asymptomatic hypertension. Patient just goes to a pharmacy and checks their blood pressure. It's 180 over, 90, and they rush to they go to the urgent care, and the urgent care sends them right to the ER. No symptoms, no end organ damage, so no chest pain, no headache, no dizziness, no symptoms. So they come in, and a lot of times they're in the ER and we just don't do anything for them. We send them out without any tests or anything because we say, look, it's not just about the number. It's about the symptoms and is it affecting any of your organs? And if you're not having symptoms, it's unlikely, right? So I would say asymptomatic hypertension, low risk chest pain, asthma, some mild COPD exacerbations, procedures like abscesses, facial lacerations in pediatrics. A lot of these things really, can be taken care of in an urgent care. And so seeing that there, musculoskeletal injuries, like, we have back pain, giving patients a false, hope that they're going to come to the ER and well, I need an MRI and the orthopedic surgeon is going to be waiting for me there, and it's just, and unfortunately it's a letdown when they get there because we just don't have the resources to do that.
Yeah.
And so unfortunately we're put in a position in the ER to explain all that. And, again, wearing both hats, I say, and sometimes I'll even call the urgent care and, try to figure it out and educate and figure out, so what were you thinking, which is why when I'm in the urgent care, I always write a note.
Yes.
And I clearly explain to the provider that's going to get the patient as to why I'm sending them there.
Yeah.
Yeah.
And that's really interesting because it's probably the most critical like opportunity for communication in the urgent care setting is if you're going to send somewhere next and it's critical, it's the emergency department. So if there's kind of that standard work in place, meaning that there's always a note or some sort of kind of clarity around what am I contemplating, what am I thinking, what am I looking to kind of rule out by sending you to the emergency department.
Right.
But then furthermore, is this an opportunity to kind of say, these are the top 10 reasons that patients are going to the emergency department. How can we narrow in the urgent care industry and really create like standards and expectations? And I think that's kind of the direction that some of the, assembly work is going, right, within UCA from a clinical decision support and quality approach is like, let's actually define these quality measures.
Right.
And if that could actually translate into less unnecessary visits going to the emergency department, how great would that be?
Absolutely.
Yeah. All right. So our audience is full of tons of leaders who are trying to push the industry forward, right? Everywhere you turn in urgent care, we've got really fantastic leaders. So from your vantage point, how do we start stretching the boundaries closer to that emergency medicine line, but not going past it, right?
Exactly.
Like we recognize there is a definitive line, but we can kind of work towards stretching those boundaries. So we don't want to fully break the model of urgent care, but let's kind of get tactical. What would it look like over the next year to 2 years to kind of start to inch towards and push that boundary towards emergency medicine?
Yeah, I think that's so important. And I think there's a lot we can do as operators, owners, I think it starts with clinical excellence. Emergency physicians are the jack of all trades, and not just physicians, PAs, nurse practitioners that have been in the ER environment for a long time. I think it starts with that clinical excellence and just investing in providers that are trained to handle literally anything that walks in and investing in education. And I think UCA is actually going that direction as well, trying to, with the quality measures, and then also they're looking at defining urgent care as a subspecialty, and I think that's all great.
Right.
So, but then protocols, right? Just standardizing things where, for example, asthma, right? Maybe we give 2 nebulizers, we watch them a little bit.
Yeah.
Are they improving? Not just like right away, just sending them, right? And so low risk chest pain as well. Maybe invest in some iStats or advanced diagnostic capabilities where you can maybe send a troponin. It's a low risk chest pain with a normal EKG. What is our protocol with these and standardize it across sites? Maybe even observing patients, like, do they need IV fluids right now? Are they really that dehydrated?
Right.
Can we, maybe give them some oral, antiemetic and watch them? And, you can have a room set aside, maybe one of your rooms is like an observation room. And you can let them sit there and see how they're responding to a nebulizer, see how they're responding. Are they holding fluids down?
Yeah.
And you can keep that patient out of the ER as well.
And you think about that full patient journey, right? It's like for that patient that had the opportunity to get their care taken care of in the urgent care setting versus getting sent to the ER and either getting treatment or not. And either way, let's be honest, it's really hard to go to an emergency department. It's hard no matter what. You can get fantastic treatment, but it's still a really kind of high intensity, high emotion opportunity and experience for the patient. So if we can be that kind of sounding board to make sure they're getting to the right place at the right time. Yeah,
I mean, we can absorb a lot of that, and you'd be surprised. It's very easy to say, just go to the ER, and it's but just putting that extra effort in. They came to you, they're not feeling well. We should do everything we could possibly do for the patient.
Absolutely.
And also think of like when that patient goes to the ER, what are they going to do?
Right.
Well, how different
what's
are they
the
going
game plan here?
Right. Like, just think forward a little bit. Like, what are they going to do?
Yeah.
So, I think, point of care ultrasound as well is another example of, I just did a course at UCA on point of care ultrasound. I think it's evolving. It's not there yet. But being able to, at the point of care, rule out a DVT, after 5 p.m. and keep that patient out of the ER, just going there just for an ultrasound.
Think about just the number of visits a year that are for rule out DVT.
Yeah.
Absolutely.
So,
and if anyone watches The Pit lately, that ultrasound is king.
Exactly. And I'm a fellowship trained sonographer. And even I'm looking at the Pit episodes. I'm like, wow, anyone that walks in
they
there
are
is getting
going
an
all
ultrasound.
in.
Yeah. So, but it's cool though. It's cool that it's really evolved into that right now. I think there's a lot of potential with that as well.
Very cool. Lots of awareness as well for emergency medicine with the Pit going kind of skyrocketing. All right. So this is a very interesting question because it spans back to pivoting to kind of think about 2021. So Acuity hit an all-time low in 2021 in the urgent care space, and it hasn't really like crazy meaningfully rebounded at this juncture. But at Summit Health, what are you planning to do differently within the clinics that you're associated with to kind of, flip that script and push urgent care to that higher acuity? What does that model look like in terms of just really looking at it differently?
Yeah, I think it's the next wave of what we need where we need to be with urgent care. Summit Health is very unique in that way because we label ourselves as a high acuity urgent care. So with that, the patients have expectations. They come in, they know if they need a CAT scan, they can have a CAT scan. They need advanced diagnostics like labs or treatments like IV fluids, IV antibiotics, all these things we can do. And so they walk in and first and foremost, it starts with the training of the providers that are working there. So it's an ER physician led group. So we have, like I mentioned before, we have 8, advanced practitioners that have worked in emergency departments for several years, and that's really how we recruit. It's only emergency medicine trained faculty there, and so they provide that high level of care. They have that experience. So sure, you're going to see a bunch of sore throats and URIs and all these, but then when that patient comes in with a headache who has a blood pressure of 200 over 100, they know what to do with that.
Equipped.
And so I love it because I can keep so many more patients out of the ER when I have that. I have a nurse that can, and I have the diagnostics that I need, and I really can do a lot with that. And so I think we're very intentional of how we don't just go, oh, it's high acuity, and we back that up with what we offer.
That's great.
And it's the clinical excellence, it's the diagnostic capabilities, the advanced treatments that we could provide. And look, at the end of the day, there are going to be people that need to go to the ER, right? Someone needs a stent. I'm not putting a stent,
Please don't do that.
I mean, they're having a stroke, right?
Yeah,
but there's a lot of middle ground that we can take care of.
Yeah.
And I think that's the next level. And I think that's where urgent care really should think about going. And it doesn't have to be full-blown high acuity. Like I said, there's a lot of things you could do at just a general site where you could observe, you can, have some protocols and give some treatments and see how they respond. And I think a lot of it just comes down to shared decision making and talking to patients and saying, look, like these are the symptoms you need to look out for. We can do X, Y, and Z here, but if you develop these symptoms, you need to go to the ER or just come back,
Create that really clear plan.
Yes, exactly. So,
well, I appreciate your perspective and recognizing there's a continuum from urgent care to emergency medicine, and that you are forging ahead in a really exciting way. So appreciate all your input into the industry as well, and your time spent really advocating for the growth and development of urgent care. So
thank you so much.
It's great to have you
on
DX.
Being here, and look forward to continuing the conversation.
Great, thanks.